Apologies for that slight glitch as usual. So today's topic is temporary pacing in the ICU, how to do and what to do. And we're talking about patients who are generally in the post-operative setting who would be requiring temporary pacing. Also talk at the end briefly about patients who don't have temporary intraoperatively placed wires. So the main talk will essentially be focused on post-operative patients requiring temporary pacing in the ICU. So what exactly is temporary pacing? It's essentially a method of temporarily controlling the cardiac rhythm by means of an epicardial or rarely endocardial leads with an external pulse generator. So external differs from what is an implantable pulse generator. So these leads can additionally be used for the diagnosis also of abnormal rhythms. So not just for therapy, but they can also be used for diagnostic purposes. And also it can be used for temporarily treating certain forms of arrhythmias, which we will discuss in our onward discussion. So if those of you who are familiar, you're surgeons, but those of you who have been to an operating room, you would see that this is the way that temporary wires are placed in the heart, and the general policy is to have two wires placed in the right atrium. And we try and place these wires as close to the sinus node as possible, but not exactly on the sinus node, so that you try and achieve, when you pace the atrium, you try and stimulate the SA node, and the further electrical conduction goes in the normal conduction pathway. And likewise, that is the ventricular wire, which is generally sutured on the right ventricular epicardium. And again, we try and put it to as close to the apex as possible, again, with the aim that the ventricular contraction starts from the apex and moves towards the base. So general policy is to put two wires in the atrium. I'll give you the reasons why, and one wire in the ventricle if the patient has come off bypass with normal sinus rhythm or some atrial arrhythmia. As long as the AV conduction is intact, then you use a single ventricular wire just as a backup. But if the patient has a heart block intraoperatively, or you have a patient, for example, with corrected transposition, where you anticipate that the patient may have post-op transient heart block, then it is safer to put two ventricular epicardial wires. So your options for any situation is either, if you're very confident it's a small procedure, you don't anticipate any rhythm issues, you can come out of the OT without any wires, or you can have just one ventricular wire as a backup. You can have one atrial and one ventricular wire, or two atrial and one ventricular wire. And as I mentioned, sometimes you may need two atrial and two ventricular wires. And usually we have one of these wires as the active electrode and the other as the neutral or the return electrode. But if you have only one pacing wire, then you can use a skin wire that can be placed later on in the ICU for a neutral lead. So we have two forms of external pacemakers. One is a single chamber pacemaker and the other is a dual chamber pacemaker. So, sorry. Jumped a bit. So this is a picture of a single chamber pacemaker, and you need to know what are the settings. So the settings are, this dial above is the rate setting. So as you turn, the rate that you're pacing it changes. This dial is the second dial is the current strength. So that's usually in volts. So the output varies from 0 to 20 millivolts here. And the third is the sensitivity. That means this allows you to change the mode from an asynchronous pacing to a demand pacing. Maybe again come to that. When we say demand pacing, we basically mean that the patient's heart rate is being sensed. And if the patient's heart rate exceeds the paced rate that you have set, then this will get suppressed and the pacemaker won't fire. When you keep it at this position on asynchronous, then irrespective of the patient's heart rate, the pacemaker will continue to keep firing. And on top, you see these sockets. This large socket is where the pacing cable actually gets connected. And there are these two sockets here where you can directly connect the metal tip of the pacing wire here in an emergency situation when you don't have a cable or you're looking for a cable. Now, there is another small chamber on top. This is for rapid atrial pacing. You can see here the normal pacing rates may vary from 100 to 150, 160 in a usual child. But here is a situation where, especially if you want to break an arrhythmia, you want to do rapid atrial pacing, then this modality is used, and it should not be accidentally used, and that's why it's kept under a special cover. You can only open it. And then again, there is no mode for you to use this continuously. So it can only be used when you press the button. So you connect the atrial wires, you can adjust this rate, and then it will fire only when you press this button and keep it pressed. So you cannot continuously pace with this. You give short bursts of rapid atrial pacing, and usually it's used to break a supraventricular tachycardia or a reentrant atrial tachycardia. And it should always be connected only to the atrial wires. You should never connect this rapid atrial pacing to the ventricular wires, because if you pace the ventricle at this rate, you will end up in a ventricular fibrillation. So that's important to note. The second type of pacing is a dual chamber pacing, so that you need to use a dual chamber pacemaker. So the previous pacemaker which I showed, that you can only pace one chamber at a time. You can either pace the atrium or you can pace the ventricle. Now, when we want to pace both chambers, the atrium as well as the ventricle, usually sequentially, then you use what is called as a dual chamber pacemaker. So there will be two sets of dials here for two different settings. But it's important to note that the heart rate setting is only single. So which is logical, because you cannot pace the atrium at a different rate and the ventricle at a different rate that way. So you are trying to achieve AV synchrony. So both chambers have to be paced at the same rate, and that's why they have not provided separate dials for an atrial rate and a ventricular rate. So there. And if you see on the top, there is a separate connection for the atrial wires and a separate connection for the ventricular wires. So now you know why you need that many wires. Now, if you are pacing the atrium, you need two wires, one pacing and one neutral. So if you have two atrial wires, then you can use both these for that. And again, you need two wires for the ventricle. So if you have only one wire placed on the ventricle intraoperatively, then you need a second or a neutral electrode, which then you'll have to place on the skin subsequently, if not. But if you have two ventricular wires, then you can use those two ventricular wires here to connect to the AV sequential pacemaker. Again, if you see the dials here, there is a rate dial, then there is a separate output. So you can change the output, use different outputs for the atrium as well as the ventricle. So that is feasible, because you may require a lesser current strength to trigger the atrium, or more current strength to trigger the ventricle, or vice versa. So that can be individually adjusted. And then here is a menu bar which will go for different other settings, because with a dual chamber pacing, there are a lot more settings that one can handle. So you can see here, once you press that, then you can first select what type of pacing that you want. The DDD means I will come to the convention of what you mean by that. So you have these various settings. You can be DOO, you can have DVI, you can have DDO. So all these can be adjusted. So this is a multifunctional pacemaker, and you can use at various levels. Then the other things that you can increase is you can increase the sensing mode. So you have a dial for the atrial sensitivity, a dial for the ventricular sensitivity. And here it's important, the AV interval is important, since you're pacing both the chambers and you're trying to mimic a normal cardiac cycle. So you need to reproduce what is the normal PR interval. So you need a gap between the atrial and the ventricular spikes, and that's the AV interval. So this is a usual cable that we have, which we connect the pacing temporary leads. So the other end of the temporary wires are in the form of needles, which can break away. And that is inserted here. And this other end of this cable goes and connects to the pacemaker. So you have some conventions you should know, that the active pacing lead is the one which is the negative electrode. So one which is marked by the negative sign is what is going to be stimulating. So if you have a single wire, then that single wire should always be in the negative electrode. The positive is the neutral electrode. So this can be in the skin, if you have only one wire on the heart. But if you say want to pace the ventricle, then you can put the ventricle on the negative and put an atrial wire as a neutral wire. So these are the common modalities that you can have. So if you want to do atrial pacing, then your negative always has to be the atrial wire, and the neutral can be either a second atrial wire, or it can be the ventricular wire or a skin wire. When you put the neutral as a ventricular wire, you have to adjust the output in such a way that it's low and that doesn't trigger the ventricular pace. If you have a high output, then even if the ventricular wire is a neutral wire, the patient can have ventricular pacing. If you want to do ventricular pacing alone, then the negative has to be on the ventricular wire. The positive can be a second ventricular wire, or it can be the atrial wire or a skin wire. And if you need AV sequential, then you need to have a combination of both. So you need one set of wires for atrial pacing and one set of wires for ventricular pacing, and you connect it to the AV sequential pacemaker. So when you do pacing, there are some common terms that we use. One is capture. What do we mean by capture? We mean that if the patient is having 100% capture, means every pacing spike is triggering an electrical activity in the heart. So a pacing spike on the ECG is followed by an electrical activity appropriately. If it's in the atrium, then it's followed by a P wave. And if it's a ventricle, it's followed by a QRS complex. Threshold. The threshold is the minimum current strength that results in a capture here. So that when you adjust the output knob, then you try and see what is the lowest that you can pace the heart at. And then after you got that lowest threshold, then you increase it by 1 or 2 volts to keep a safety margin. You don't want to pace the heart at an excessively high output, because every artificial electrical stimulation has a potential to cause damage. So we don't want to do that. The third is the sensitivity. Again, the sensitivity is the lowest electrical cardiac strength that the pacemaker can sense. So sensitivity is important when you're going on to demand pacing. You don't want the pacemaker to be too sensitive so that it gets suppressed even by non-cardiac electrical activity, like for example, muscle activity or other. At the same time, you don't want the sensitivity to be placed so high that the pacemaker does not get suppressed by the cardiac activity. Then running through. And we say that, oh, the pacing is running through. This means generally the patient's own rate has become greater than the pacing rate that you have set it. So the pacemaker is no longer effective and the patient's heart rate is running through your paced beats. So when you attach a temporary pacemaker, what are the settings that you need to adjust on the temporary pacemaker? They are different for a single chamber as well as a dual chamber pacing. So you have connected the pacemaker. As I have told you earlier, the appropriate leads have been connected. Important to remember again that the pacing lead is always the negative electrode. So in a single chamber pacemaker, it's important to set the rate, then the and then a decision as to whether you're going to be putting on demand or asynchronous. Important here to realize that the atrial pacing is always asynchronous. In the atrial pacing, demand mode doesn't work because the atrial electrical power that it generates is very, very low for the pacemaker to pick up. So you cannot have a demand pacing in atrial pacing. So atrial pacing is always asynchronous. And again, it is safe because even if the patient's own rate picks up, then all that will happen will be some competition. You're unlikely to generate or trigger a dangerous arrhythmia. Ventricular pacing is generally kept on a demand pacing unless you're very sure that the patient has a definite complete heart block and his own heart rate is unlikely to pick up. But if it's a transient heart block, then it's generally preferable to pace ventricle on a demand mode, because occasionally when you're not observing, the patient's own heart rate can pick up. And then if the patient's heart rate pick up, then you can have what is known as an RNT phenomenon, that you can have pacing spike occurring on the T wave of the patient's own QRS, and that can trigger a ventricular arrhythmia and sometimes a ventricular fibrillation. Dual chamber pacemaking has different settings. Again, you have connected both the atrial as well as the ventricular leads appropriately. The first thing you need is to set the rate. And the rate will depend upon what physiological purpose that you want to achieve with the pacing. So it will depend upon from patient to patient, depend upon the post-operative status, depend upon what surgery has been done, etc. The atrial current strength you set first and make sure that the current strength is adequate enough to pace the atrium. Again, as I mentioned, the atrium is generally kept as a asynchronous mode. Then you connect the ventricular current strength. Again, have the ventricle output adequate enough to have a 100% capture of the ventricle. Then you adjust the AV interval. And AV interval, you can normally adjust. It depends upon the heart rate. So the higher the heart rate that you set, the lesser will be the AV interval. The lower the heart rate, the higher the AV interval. So it generally ranges between 90 and 120 milliseconds. But the other thing that you can do is also to observe the hemodynamics, observe the blood pressure trace and the CVP or LA trace if you're monitoring. And then you adjust the AV interval to a level where you get the best hemodynamics, which means the lowest CVP and LAP and the highest arterial blood pressure. And then you adjust the mode, whether you want a totally demand mode. As I mentioned that this DDD mode is usually for endocardial pacing or epicardial pacing. Normally, you put a dual chamber pacing, but you generally either go to a setting where both are asynchronous, or you have the atrial asynchronous, but the ventricular as a demand mode. So as I mentioned, you adjust to achieve the highest arterial blood pressure and the lowest CVP. Now, as I was talking earlier, these terminologies, DDD, DOO, etc., is based on the terminology governed by the Heart Rhythm Society and the British Pacing and Electrophysiological Group. It's a generic code which is universally applied. When we say it's generally used three alphabetical letters, and these three refer to A, the first one refers to the chamber paced. So when we're using the pacemaker, obviously there'll be no zero. It'll be either atrium or the ventricle or dual. So when we're doing dual chamber pacing, it's the first letter is always D. That means you're pacing both atria as well as the ventricular. What is the chamber sensed? Are you sensing neither of the chambers, which means both are in asynchronous mode? Or are you sensing atrium alone or ventricle alone? Or you're sensing both atrium as well as ventricle? The third is the response to the sensing, which means A, you set it that the patient, it can sense, but it should not do any response. T is triggered, that means it responds to the sensed pacing. And I is inhibited. Inhibited meaning that if the patient has his own spikes, then the pacemaker gets inhibited. So when we say DVI, I mean it's dual chamber pacing, atrial and ventricular. The sensed chamber is the ventricle, and the action that will happen is that it is inhibited, which means that the ventricle is on a demand mode. If the patient's ventricular rate goes up beyond the set rate, the ventricle will not fire the ventricle. So just to show, it's important to realize not just to connect, but that you are doing appropriate pacing. Very often we've seen that the pacemaker has been set for one particular mode, but actually what is happening is that on the ECG trace, it is pacing at a different mode. So you need to know what the ECG tracing looks like for atrial pacing, ventricular pacing, and AV sequential pacing, and I have shown all these three modalities. Remember that these monitors are set that it shows up the pacing spike either as a dot or as a spike on the ECG. Like on upper trace, you can see both a dot as well as a spike. And the spike is white in color. It's not the same color as the ECG. So when you see this, and plus it doesn't have any width, it is just a sharp line because it's the pacing electrical output is of a very, very short duration. So it just comes as a spike. So when you see this, you know that this is the pacemaker spike, that this is the electrical activity of the pacemaker. So when you have atrial pacing, proper atrial pacing, then there should be a gap between the atrial pacemaker spike and the QRS complex. So that is what I mentioned is the normal PR interval. And then there should be a regularity between the pacing spike and the QRS complex. So now you see here that the pacing spikes are occurring regularly and the QRS complexes are also following regularly in a 1:1 fashion. That means each pacing spike is being followed after a gap with a QRS complex. So here you have atrial pacing with 100% capture. Now how does it reflect? You can see that the central venous pressure has a normal tracing, the normal AC and V waves, so that when this atrial pacing, it almost mimics the normal cardiac cycle. And so you have a central venous pressure with a normal tracing. Now, the second thing shows ventricular pacing. Okay. Now, what is the difference between these? Is again, you see the pacing spikes and you see QRS complexes. But what is different? You see that there is no gap between the pacing spike and the QRS complex. There is only one pacing spike and each pacing spike is followed by the QRS complex. So this is a situation where there is isolated ventricular pacing. Right? I don't have a good enough CVP tracing here, but when you have a situation when you're doing isolated ventricular pacing, the atrial rate will be different from the ventricular rate because the atrium is not being paced. It might be slower or it might be faster. But then you will see that the CVP trace will not be regular like this. You'll have a very erratic central venous pressure tracing, and the CVP will usually be higher. The third is the AV sequential. So as I mentioned, when you're doing AV sequential pacing, you're pacing both the atrium as well as the ventricle. So now you can see that for each cardiac cycle, there are two pacing spikes. The two dots. The second spike is not very well seen, but you can see here the larger spike and the smaller spike. So there are two spikes, one for the atrium and one for the ventricle. So again, as you see here, you got a atrial spike, there's a gap, there's a ventricular spike, and there's a QRS complex following the ventricular spike. So there is a regularity here, both atrium and the ventricle being paced. And again, as you can see, that the central venous pressure, if the atrium is stimulated at the same rate, you will get a reasonably normal central venous pressure. What usually happens in most of these situations is that the patient is in complete heart block. The atrial rate, because of the inotropes and all, is much higher. It might be 150, 160, but you don't want to pace the ventricle at that rate. So even though you're connected to atrial, the atrium is usually not pacing. The atrial rate is higher than what you have set. What's most important is that your ventricular rate should be reasonable and the patient's hemodynamic should be adjustable. If, of course, both the atrium as the ventricle are pacing, innate rates are low, then you can get a good AV sequential pacing. So sometimes you have a situation like this where your pacing spike seems to be falling just beyond the QRS complex, but it's all regular. And there's a wide gap between the pacing gap and the next QRS complex. So why does this happen? Does it mean that the patient is not pacing? But the patient is pacing here, and it is atrial pacing because the QRS complex is coming before. It's not coming after the pacing spike. There's only a long gap between the pacing spike and the QRS, and all this means is that the patient has a prolonged PR interval. That's a prolonged intra-atrial conduction. So this is still atrial pacing, but with a prolonged PR interval. So I've shown you the modes of pacing: atrial, ventricular, AV sequential. Now, when do you actually use this temporary pacing? So the most commonest use is to augment the patient's heart rate and thereby augment cardiac output. Basically, we know that in children, especially neonates, the cardiac output is very dependent on the heart rate because the stroke volume cannot adjust too much. Stroke volume does not vary. You cannot increase stroke volume even by inotropes. So the cardiac output is very dependent on heart rate. So in a post-op patient, especially TAPVC or a TGA, they like higher heart rates rather than lower heart rates. And some other patients may also have sinus bradycardia. So in order to improve the cardiac output, you can use temporary external pacing rather than resorting to chronotropic drugs, which have their own side effects. The patient with sick sinus syndrome, especially if you have worked in the region of the sinus node or accidentally injured the sinus node during surgery, then the patient may not have a normal generated P wave. And so in that situation, in a second or third degree heart block, of course, in conjunction with ventricular pacing, then you need, so in these situations, you are likely to need AV sequential pacing or isolated ventricular pacing. But here just atrial pacing alone will not help in a third degree heart block. So as I mentioned, patients with regressed left ventricles or borderline left ventricles like to have a higher heart rate in order to maintain cardiac output. Then sometimes to manage arrhythmias, especially ventricular ectopic, escape bigeminy, junctional escape rhythm. Now, these are situations where the arrhythmia basically originates because of an innate slow heart rate. So ventricular ectopics can occur sometimes when the basic sinus rate is low. So if you increase the sinus rate by means of pacing, the ectopics can be suppressed. Likewise, escape bigeminies can be suppressed by pacing the atrium at a higher rate. Supraventricular tachycardias, reentrant atrial tachycardias can be broken with overdrive pacing and occasionally even by underdrive pacing. The heart rate patient is beating at 220, 230 heart rate. You can just try and pace at half that rate, and very often the atrial tachycardia can break. Alternatively, overdrive pacing, you pace very briefly for a few seconds at 300, 350 atrial rate, and that can break the SVC. But this is assuming that all other metabolic parameters are all right, the potassium has been corrected, the magnesium level is all right, then you can attempt these. Likewise, junctional ectopic tachycardia, if we can pace at a higher rate than the ectopic tachycardia, and there is 1:1 conduction, then you usually know that it's not a ectopic arrhythmia, but it's more a ectopic tachycardia. You can record atrial electrocardiogram. That's very important as a diagnostic tool. When you record atrial electrocardiogram, then you can get very clear, prominent atrial electrical activity and the ventricular. So you can separate the atrial and ventricular activity. And this is very useful when you have situations of atrial flutter or jet or complex rhythms where it's very difficult to make out. So essentially that you need to connect all these leads to the ECG machine. So you have the standard limb leads as well as then you connect the atrial wires. Yeah. So you connect the atrial wires to one of the electrodes that's shown here. And then you surface electrocardiogram. And then you can get very prominent both R waves as well as the P waves. So in this situation, you can see that this is the R wave, which is the QRS complex, and these other smaller beats are the P waves. So you can differentiate now. This is, of course, a normal sinus rhythm, but just to show that how the PQRS looks in the normal ECG and how it looks in the atrial electrocardiogram. So very sharp, tall P waves and QRS waves. So you can differentiate too. So you have a situation where there's an atrial flutter. So you can see that on the top ECG, it looks sometimes almost like a sinus rhythm, one P wave, but you look at the atrial electrogram, you can see that there are multiple A waves and the V wave is only episodic. So the atrial rate is much higher than the ventricular rate, but the ventricular rate being regular, it just indicates that it's an atrial flutter with a fixed block. Here's an atrial electrocardiogram showing atrial flutter. So you can see these spikes are all the P wave spikes, and these taller ones are the QRS. You can see that the QRS rate is irregular. So sometimes it's coming after 3 atrial beats, sometimes after 2 atrial beats, sometimes after 1. So it's atrial flutter with a varying block. If there was atrial fibrillation, then you won't see any P waves at all, and you'll still see a varying QRS complex. So it's a junctional escape rhythm with absent P waves. You can see on the surface ECG, you don't see any P waves. But when you look at the atrial electrocardiogram, you can see that the P wave is retrograde. So there's an escape junctional rhythm, and there is a P wave, but it is not following the QRS complex. The complete heart block, you can see that even the surface EG you can make out, but you can make out more surely on the atrial current that the P wave and the QRS are occurring at different rates. And there is total dyssynchrony between the P wave rates and the R wave rates. So in complete heart block, the treatment is again, as I mentioned, to do AV sequential pacing. And to do AV sequential pacing, then you can achieve AV synchrony. The another situation, we must identify this. Sometimes you may feel you're not pacing and the patient is having only some beats paced and some beats not paced. You may think it's a problem with the pacemaker, but it's not a problem with the pacemaker, but it is what is known as a rate-dependent heart block, which means that the conduction system is able to conduct only up to a particular rate, and beyond that rate, it does not conduct. So here we are trying to pace at a much higher rate, but as you can see that not every pacing spike is followed by a QRS. So this is followed by a QRS, this is followed by a QRS, but this pacemaker spike does not followed by a QRS then again. So this is being paced at a higher rate than the patient can tolerate. So it's a rate-dependent heart block, and when you reduce the pacing rate, you can see that you get a 1:1 pacing. So it's a situation with a rate-dependent AV block. So this is important to know so that you can adjust the rate to an appropriate level. You can see the effect of higher heart rate in increasing cardiac output. So both things, how do we indirectly assess cardiac output? One is the rise in the blood pressure and a drop in the filling pressure, which is the CVP or the left atrial pressure. So here is the patient, the post-arterial switch, and we are pacing here at a rate of 154. You can see the mean blood pressure is 44 and the left atrial pressure is 12. I increase the pacing to 166 and the pressure has gone up slightly. But what's more important is that the left atrial pressure has come down. And I go the pacing at 170 and my mean blood pressure has remained the same, but my LA pressure has come down further. So it's important that in the post-op period, these are simple manipulations that you can do to improve patients' hemodynamics without any significant side effects. So it's very innocuous. So atrial tachycardia with aberrant conduction, you can see here, the QRS complex is broad. It's a 1:1 conduction. The patient having a normal sinus rhythm, but it's a abnormally conducted QRS complex because it's broad. You can see from the CVP also that the CVP is uniform. They pace this patient atrially because the stimulus is occurring from a different site. It conducts through the normal pathway and the QRS complex is immediately normalized. So same patient, 173 innate heart rate, I'm just pacing at a slightly higher rate of 179 and that normalizes the QRS. Not much difference in the hemodynamics. Blood pressure has gone up a bit from 45 to 50. CVP remains the same, but you have a more normal. So again, here you can use this as a diagnostic modality. You know that the patient is capable of having a normal QRS, but that this QRS then is not a ventricular arrhythmia, it is aberrant conduction. So here is a situation where we have broken the SVT with an overdrive atrial pacing. So you can see in the beginning part, this is supraventricular tachycardia, and we've started burst pacing at this point of time. And immediately as you start burst pacing, it is broken and you're getting a normal sinus rhythm. So overdrive atrial pacing is used therapeutically. So what then are the advantages of temporary pacing? A, you can get an instant hemodynamic response. You don't have to wait for some time for the drug to take effect or something. It's instantaneous. There are no side effects, can be instantly switched off if it is not working properly, and then can be used for several days without significant ill effects. So the ill effect is that, yes, the patient's own heart rate may get suppressed for a while, but usually that recovers very fast. And then there are many adjustable modes to optimize the hemodynamics, as you already mentioned. That there are some complications of temporary pacing, and these are basically related to the placement of the temporary wires. So as I mentioned, inadvertent ventricular pacing, bilateral pacing. So sometimes if you set a higher output than is required, the ventricle can get stimulated even if the ventricular wire is not connected to the pacemaker. If the pacemaker wires are placed on the undersurface of the ventricle, sometimes you can pace the diaphragm and you can get painful diaphragmatic pacing. It can also occur if you're using a skin electrode as a neutral. And if it's close to the diaphragm, it can stimulate the diaphragm, or the output is high, then it can be quite painful because the electric current passes through the skin with every stimulus of the pacemaker. As I already mentioned, you can get ventricular tachycardia or fibrillation if there is a R-on-T phenomenon. So the ventricular pacing is kept on asynchronous mode, and the pacing spike falls on the T wave, then one can trigger a V fib. Therefore, that's why it's always safer when you're doing ventricular pacing is to keep it on a demand mode. A pacing wire tip can cause surgical issues. If it is placed close to a coronary artery, the tip can sometimes erode through a coronary artery, or anteriorly, as the heart rubs against the anterior chest wall, it can erode into the internal mammary artery. And we have had instances where patient has had cardiac tamponade because of bleeding from this. Wires, if they're not removed completely at the end of the required time, and if you just cut the wires and leave the distal end, then one can have pacing wire site infection, and it can cause troublesome sinus formation. So always a good idea to remove pacing wires or pull them out fully rather than cut them. What are the problems encountered during removal? Sometimes wire can be stuck, especially while closing the sternum. If inadvertently the wire has got trapped within the sternal sutures or the sternal wires or between the sternal blades, then it may not be possible to pull it out. When you pull it out, if it's, again, as I mentioned, close to a coronary or sometimes the right atrial wall, if the suture which is placed to hold the wire is placed too deep, then it can tear the atrium. And as I mentioned, if wires are cut, then sinus formation can occur. What can we do if the patient doesn't have temporary wires and he requires spacing? Now, if it is in a situation where an acute emergency arises, and this usually arises when the patient has suddenly either had a cardiac arrest with asystole, or the patient has gone into sudden acute heart block. That can happen in a patient, for example, with corrected transposition. They can have acute heart block, and with acute drop in or severe bradycardia resulting in hemodynamic compromise, and you want to immediately pick up the heart rate. Now, as an alternative to using inotropic agents, but even inotropic agents will not help if the patient has a heart block, then you can use the defibrillator, which current day defibrillators also have a unit for external pacing. With external defibrillator paddles, one can connect those paddles and connect it to this external defibrillator unit, and you can do transcutaneous pacing of the ventricle. I'll show the pictures. You can do this till the time you can take the patient to the cath lab or on the bedside, place a transvenous pacing lead and connect it to them. So this is a temporary modality, but it can be life-saving in situations with severe bradycardia with sudden onset AV dissociation, where you can pick up the ventricular rate and can at least provide temporary ventricular rate command. The only situation to note is that you can do only ventricular pacing with this. You can't do atrial pacing with this setup. And it will not help if there is electromechanical dissociation. So the electromechanical dissociation, even if we are able to pace the ventricle and the ventricle is not contracting, then the patient will not be helped because you won't be able to generate a cardiac output. So what is this modality? If you look at your defibrillator machine, if it's a current one, you'll see a small module here, which is the pacer module. So this is a pacer module. You can switch on the pacer module. You have to connect the external paddles to the pacemaker. This is all connected. You can adjust the rate. You can here also put it on a specific demand, and you can increase the output. So basically rate, output, and on both mode, whether it's demand or in a asynchronous mode. Usually in this sort of situation, you'll be only using an asynchronous mode. And sorry. So these are the sort of external pads that are available. You can use pediatric, and this is the way that it is stuck. One on the front of the chest, one at the back of the chest, and then the leads are connected to this pacemaker, and you can pace this patient externally without, when a situation where you don't have temporary pacing wires. So to summarize, temporary pacing wires are an irreplaceable asset in the postoperative care. Every ICU care physician should be thoroughly aware of the various ways or modalities of pacing and how to use temporary pacing effectively, not just for rescue, but also for optimizing postoperative hemodynamics. Atrial electrocardiograms is very useful for diagnosis of complex arrhythmias, and most arrhythmias can be reverted with pacing, thereby avoiding antiarrhythmic drugs, which can have significant side effects. So that is a brief summary of what can be done in temporary pacing postoperatively. I've gone through the various modalities of pacing. So now if there are any questions, I'll be quite happy to answer them.